Do that. Thank you. Again, my name is Dr. Lauren Snedeker. I'm the certificate coordinator for the Aging and Health Certificate Program at Rutgers School of Social Work. This certificate is available to MSW students who are focusing on clinical practice as well as policy practice. I'll attach the brochure and my email in the chat. So if you're interested in the certificate or interested in joining me and the work that I do at this school, don't hesitate to reach out to me. I love connecting with students as a faculty member. It brings me great joy. I'd love to introduce you all to William Andrews, who is a licensed social worker, an alum of the certificate and of our MSW program. He will be speaking about his experience in hospital social work, entitled Hospital Social Work, a 101. And I'm going to go ahead and share my screen, and Will, take it away.
Greetings, everybody. So as Dr. Lawrence said, my name's Will. I'm a licensed social worker in this great state of New Jersey, and I have been a hospital social worker for 2 years at Robert Wood Johnson, right in New Brunswick. So a little bit about my background. So next slide, please. Thank you. For my undergraduate, I got a BA in sociology, Drew University, class of 2018. I automatically enrolled for the MSW in class of 2020. So I was a clinical student. I was in the Aging and Health certificate. I was an Aging and Health fellow, so I had to do a special research project. And then just because I was really interested in hospitals from the get-go, I created a special hospital social work area of emphasis. My first year internship, I did complete that at Jewish Family and Children's Services in Mercer County because they worked a lot with the elderly. And then my second year internship was at Robert Wood, and I have been there ever since. So that was 2019 when I started, and then 2020 I got hired as a full-time employee. Next slide, please. So my current role, I'm a social worker at that hospital. My primary function is to be a discharge planner. So what that basically means is when you're working with the medical team, as a patient is going through their treatment, we're in a role that's called either care management or case management. And our job, along with the nurse case manager, who's our coworker, we come up with the safest discharge plan for the patient. And that could be either back to their home with resources, or it could be to a different facility, such as subacute rehabs, acute rehabs, sometimes psych placement. It depends specifically on what they need. Now, in unique to at least to the Barnabas system, because Robert Wood is the flagship of the Barnabas system, in my particular role, I only do discharges to facility, whereas my nurse counterpart does discharges to home. In other care management departments, it's a little more common for us to do the same job, but the difference is we're coming at it from a more psychosocial point of view, whereas obviously the nurse, they have the medical background, they're looking more on the medical side. I have covered in orthopedics. That's where I first started. I had a decent amount of time in neuroscience, and I'm currently in medical oncology, but I've also floated throughout the whole hospital. I know a ton of different people, nurses, PTs, techs, docs. But right now I've been in medical oncology since April. So that's the longest I've been on a particular unit. So it's about 6 months, I think. Next slide, please, Dr. Lauren. So I know one of the questions that Dr. Lauren brought up to me was, what's a typical day like? And first and foremost, when I get in, my hours are 8 to 4:30. Obviously, I sometimes get in early, I sometimes stay late, but my official hours are 8 to 4:30, Monday through Friday. First thing I do after I eat breakfast, because I always get it at the cafeteria, is I review my notes on my patients. I have a census of about 31 patients to start. And that varies by the day, because some days we have more coverage, some days we just have our particular unit because we're unit based. But the first thing we do post that is we round with the medical team. So that consists of the doctors, the nurses, you have your physical therapist, your occupational therapist, and the RD is the registered dietitian. So we're all looking at a patient, a set of patients from our particular vantage point. Now, the doctor drives the care. So anything he or she wants in terms of like medical testing and procedures, they are the ones who order it. They're the ones who put in the discharge order. The RNs, who I personally argue are the the eyes for the doctor, they are with the patient for their full shift. So if it's 12 hours, they're there for the 12-hour shift, and they are the eyes and ears for us. They obviously make sure that the patients are medically okay and they follow the doctor's orders. PT and OT is pretty self-explanatory. That's physical therapy, occupational therapy. They are specifically evaluating patients to see where they need to go post-hospital. Can they go back home, or can they go to rehab? And then the dietitians are obviously looking at the diet orders. Now, for us in our case management, care management role, we're specifically looking at what is the discharge plan. So from the moment a patient comes in, we are starting to plan a discharge. Now, that can change very quickly. It is a hospital. I cannot joke enough about how often plans change. After I round, and that takes about 30 minutes, 45 minutes, I review my census again. I then, throughout my day, I'm interacting with patients at bedside. I interact with families at bedside or on the phone. I'm constantly documenting, hence the meme, social worker. You're saving the world one progress note at a time. And then I'm constantly communicating with various departments and organizations. So I'm constantly talking to the nurses, the doctors, outpatient and inpatient facilities such as rehabs and nursing homes, psych placements, insurance. I'd make the joke, even though it's true to some degree, and I explain this to the patients and their families. A lot of my job depends on people kind of doing theirs, because I have to coordinate everything. So if a patient needs to go to rehab, I need to make sure the therapy note is correct. I need a doctor's order to specifically say discharge the rehab. If there's a test that needs to be done, I need to make sure it was done. So a lot of juggling, but that is my typical day in a nutshell. And there are days where I am constantly running around like a headless chicken. And then there are days where it's really, really slow. And I sometimes don't even get to eat lunch till almost the end of the business day, but that's a whole nother discussion. Next slide, please, Dr. Lauren. So how did I personally prepare for this role? That was another question. When I got the internship, when I was with my supervisor, everything she did, I literally just wrote down how to do it. Like, this is how you make a referral. This is how you complete a care plan evaluation. And I can explain more of that in detail, in the Q&A section. I always asked a lot of questions, and I placed it in my binder. I typed it up. I did make sure to learn the basics of Medicare and Medicaid, because a lot of our job is, built around that. So the way I really also describe our role in care management, or more specifically social work, is everyone's looking at the big medical picture. And of course we do that, but we handle all the non-medical issues that patients and families have to, run into. And I can't tell you how many times when we're rounding, like these nurses and these doctors are asking me, well, do you think they're eligible for that benefit? And now in the beginning, I will admit I was deer in the headlights. I didn't really know the answer. Since then, I've learned a thing or two. I have taught myself some that's not a word, some basic medical terminology, mostly because we're always talking about, CAT scans, so CT scans. Are they getting pegged or trached? Like, that's all important to know. Now, again, kind of like I don't expect a nurse or a doctor to fully understand how Medicare works. They're not going to expect me to understand that an IV goes through this particular vein and then they have to draw it this way. Like, so, we stay in our own zones, but we still work as a unit. And then the last thing I had to learn was a lot of de-escalation techniques. And it's mostly because of family members, every so often patients, because we're dealing with people in a crisis. They are hearing things they don't want to hear. And sometimes you got to start with a patient or family's ad. They don't want to hear it. Sometimes you got to calm them down, and it's easier said than done. But that was one of the last things that I taught myself, and I'm still learning new methods. So, and full disclaimer, I've only been at this job for 2 years. If you really want to be technical, 3 if you count the internship, and I'm still learning things constantly. Like, yes, I'm a resource and people come to me and I have an answer to a lot of things, but I make errors. So that's just a full disclaimer. Next slide, please, Dr. Lauren. Why should you consider hospital social work? I'm going to give you the really pragmatic answer first. It is a growing field. According to the Bureau of Labor statistics, at least when I was looking back in undergrad, and it was, I want to say 20+% for growth between 2016 and maybe it was 2028 or something like that. So from the pragmatic side, like you're always going to have a job. And I should also, in full disclaimer, mention that even though like I'm primarily focusing on hospitals, that's medical social work in general, because you could also work in a rehab, a psych facility, whole 9 yards. Second point is there's a ton of variety. And what I mean by that is not every patient is the same. Yes, I'm primarily, sending patients to facilities, but everyone has a different story. Everyone has a different need. Some patients I need to help with like Medicaid and food stamp applications. Some patients need letters to be sent to embassies to have family members from different countries flown in. The furthest I've ever discharged a patient, I had a patient in Arizona who was from Arizona who came to us during Hurricane. What storm was that last year? But the storm last year, and he got COVID and he got sick. So I had to coordinate with a time difference of 3 hours with a family, with an insurance company, with rehabs. And that was a lot of work, but I got him safely to Arizona. Third thing, and this is the most important thing for me, is infinite amounts of learning. I'm constantly learning about the new regulations. I'm constantly learning how to interact with patients. I'm constantly learning how to work better with the team. And every time I think I know what I'm doing, I can jokingly say there's a monkey wrench thrown at me and I'm like, what the heck is that? And I have a deer in the headlights face like right now. Constantly learning. And that's really important for me. I'm never bored, except when it's slow, but that's a whole nother thing. And the last thing is you see the impact that you have on patients and their families. Now, again, I talk about this with all my friends who are nurses and PTs and OTs, because I've made a lot of good friends while working at Robert Wood from the different disciplines. It's different for us. Like we all impact the patient and the family, but we impact them in different ways. So obviously for the nurse, they're there at bedside, they can see the patient go from being sick to getting better. Whereas for me, because I'm making sure that the non-medical side is taken care of, if a patient doesn't have insurance, like I can get them started on that application process. I can get them started to get them to a facility so they can get better to go home, and things like that. And that makes the job, at least in my opinion, extremely worthwhile because you are seeing that impact. Next slide, Dr. Lauren, please. And this is how to launch yourself into the career. So again, I'm going to hit you with the pragmatic answer first. Make sure your second year internship's at a hospital. Like that's pretty obvious in my opinion. Make sure you make a great impression on everyone in the department. That includes your supervisor. That includes the team lead. That includes anyone you come in contact with from the department, other social workers, case managers who are RNs. And I should also maybe add, just be a decent person to everyone you interact with, doctors, nurses, the whole 9 yards, even the janitors, anybody. And then ask your supervisor a ton of questions and make sure you write that stuff down. As I said, I'm constantly still doing that. And that's important. And then make sure you try to obtain that basic knowledge of Medicare and Medicaid. It is vitally important, especially in our role. And there are times where I've had to correct doctors, and when they're like, "Oh, can a patient do this?" and I'm like, "Yeah, where's my magic wand?" Or Lord of the Rings. Am I Gandalf? No, I can't make that happen. Okay, thanks. And then another thing, obtain your basic understanding of medical terms and procedures. Now, again, we are not nurses and doctors, so I don't expect any social worker really to be like, okay, the patient has this kind of blood clot. Now I think they should really be getting this kind of test. I would never, ever at rounds bring something like that up. It's not my wheelhouse, and I probably would say the wrong thing anyway. And then the last thing, again, it's another pragmatic thing, pass your licensing exam. At least in the Barnabas system, I can't speak about Hackensack or Atlantic Health, but at least in Barnabas, we don't hire social workers unless they have their license, at least the license number, I should say. That's basically it in a nutshell. I'm interested in your questions. I kind of threw a lot at you. So ask away, because I wanted to give you guys as much time as possible to pick my brain and everything else.
I'm going to go ahead and stop sharing for this portion. And if you have questions, please feel free to take yourself off mute. Let us see you if you're in a space and a place to do that. I have some questions too, but let's see if our attendees have anything they want to ask.
I don't bite, so.
And you have a lot of knowledge and experience. And I will say that there's a lot of discussion about the licensing exam, given new recent reports and information. And we at Rutgers School of Social Work will be having an event to discuss this in more detail, I think next week or towards the end of October. But at this time, I would say just for those who are very fresh to the field, most hospitals, either RWJ or Hackensack, do require that license, just so you're prepared. Tyrell is one of our amazing Aging and Health Certificate students and also a TALB Fellow. Go ahead, Tyrell.
Hi, Dr. L, and hi, Will. So I'm currently at a outpatient center working with cancer patients. I love my field placement. I feel like I've learned so much so far being here. It's helped to strengthen my case management skills, and I really feel like, so far I'm just, taking everything in and is learning as much as I can from my supervisor. I wanted to know, so once I complete my field placement, I'm looking to become licensed. I know after licensing, if you can find someone to supervise you so that you can get your clinical. Is it easy doing that in the hospital? Is that easy to find someone to supervise you in the hospital once you get your license?
Hi, Tyrell. Yeah, no, that's a good question, especially if you want to go the clinical route. I will be very upfront about that.
Yeah.
You need to make sure that the particular health institution you're at, be it a hospital or outpatient or inpatient facility, has a job description that has some kind of clinical mention within it. Because in my particular role as a discharge planner, I would not meet criteria. So even though we try to get social workers in and say we could offer you supervision, we constantly are having issues with the social work board, because in what I just presented to you, does anything outside of interacting with patients sound like clinical? And I would argue it's a stretch saying that me talking to patients is clinical, because I'm not doing group therapy or anything like that.
No, it mostly sounds like how you said, like discharge, like you're dealing with patients, you work with the other members of the healthcare team to basically coordinate care, to provide the best optimal care possible to the patient, because, that's our job as, social workers. But I know that for me, I'm going the clinical direction, and I wanted to know, like, is it easy finding supervision in the hospital? Is it better for me to go to private practice? But I appreciate you.
Yes, I'll try to answer this as politely as possible. So it depends on the particular institution. So for example, in Hackensack Meridian, they have carrier clinic. So you would definitely meet criteria there.
Okay.
Whereas in Robertwood, New Brunswick, where I work, we don't really do anything when it comes to psych patients or anything of that kind of clinical nature. But I believe Robertwood Somerset has like a psych wing. So it would be easier for you to get it done there. make sure regardless of where you go, that the place has an LCSW on staff, because otherwise we're all LSWs, and I can jokingly say, like, I think I might be great, but I can't supervise anybody. So just, those are the two things or three things. Make sure the job title and description have some mention of clinical, and the guidelines are very specific. You could find that online from the state and the board. And then the second thing is make sure you have a supervisor on site. And then, those are the two big things. And the last thing I will say, and I say this to everyone who's interested in the mental health side, the hospital role that I'm currently in, we get paid in general now a little better than the nonprofit sector. And there's some data to back that up, because I know I had some coworkers who left nonprofits because they were making, in their exact words, peanuts. Now, I'm not saying, to poo-poo anything, but I'm just trying to be upfront about that. Make sure you're matching your salaries and everything like that. So in full disclosure, there's pros and cons to what ever you do, but given that you like where you're at, given that it sounds perfectly clinical, in my opinion, from what you just told me, I think you should be fine. Just make sure you have an LCSW who can supervise you, and you could easily just ask that. You're an intern right there, so you could ask them right now.
Yes, thank you.
Thank you so much, Tyrell. And I just want to answer as an LCSW myself and on behalf of the school, and just to add to what Will mentioned, just a few things. And then I see Mimi has their hand up. So we'll get to you in 1 second, Mimi. So thank you so much, Will, for your responses, and Tyrell, great question. Just a few things. So arguably and respectfully, although hospital social work might not feel like a very true clinical, at least internship, I'm sure that Will could agree that even the de-escalation techniques does involve some clinical practice. And there also could be, or clinical skills, and there also could be some sort of clinical skills entering, of course, depending on, the units and the patients that you're working with. But I always also think of motivational therapy techniques, change, cognitive distortions, kind of trying to help clients or patients, rather, in this setting, re-envision where they are, where they're going to be. Because as I always like to say, as a former discharge planner myself, sorry, my child, you could make the most beautiful discharge plan in the world, and I'm sure Will could agree, just tie it up with a bow. But if the person has no motivation, if they're clinically depressed, it's going to be a very difficult time for everyone. So I do think there are clinical skills that you're utilizing in this setting. However, as Will obviously presented on, there is a lot of focus on other techniques and other practices that, of course, are a part of the MSW program and a part of being a social worker. The other thing I wanted to mention is that when you're going on interviews, absolutely, as Will said, ask about supervision. If it is a goal of yours to have your C, to be a clinician, to maybe open a private practice or be sort of, a supervisor or director of services yourself. Not all positions require the C, but if you'd like to do private practice and bill insurance, you will need a C, clinical licensure. And just because a person has their LCSW does not mean that they can supervise. Actually, there's an additional training. So even though you're looking for the LCSW person, also ask if they're prepared to provide the supervision and have that additional kind of criteria, because they could have, many LCSWs at the placement. However, no one is in position to supervise, in which case you might look to outside supervision, which you'll pay for, but in some cases, of course, it's worth it if that's the journey you want to be on. And I think that's all.
Yeah. Good point, Dr. Lauren. I completely forgot that even though it's important to have the LC on staff, they need to be registered in the database.
They have to take exactly. There's a second step to the supervisory process. And it's not something that you have to supervise a student. In the same way, of course, we offer the SIFI course to supervise a student. But the other training is much more in detail because it's a little bit, more intense, of course, the level of practice. So enough of that. So we have a bunch of questions.
Yes.
Yes, go ahead. We'll go down the line. Mimi, thank you.
Hi, everyone. Will, my question to you is, do I have to have a clinical degree or management and policy before I can do a hospital social work? Because from what you're saying, it seems like we wouldn't be using all the clinical skills in the clinical class. So is it better? Because I am always going back and forth between clinical and management and policy. But now my internship is actually in a clinic and I love what I'm doing in the clinic. So I was thinking about possibly doing clinical social work to work in a hospital. But from just the conversation a few minutes ago, I don't know if it's better to get my MAP and then do hospital social work, or can I do hospital social work with MAP, or I can't?
Yeah, you can.
You can.
We have a person who's been in our department for almost as long as I've been alive, and she was a MAP student.
Awesome.
Yes, you can. Because at the very end of the day, you are still getting an MSW.
Yep.
And the MSW is sort of the entryway to then become licensed. You obviously, hopefully this is obvious. I apologize if it's not, respectfully, but as an MSW, whether you have your clinical or your MAP sort of focus, you can sit for the licensure exam and you can certainly go in. I had a former MAP student who just got hired at Hackensack Meridian. So I know we make you choose what you'd like to do, but as Will said, you can really kind of explore, and I encourage you to explore and think about what you'd like to do now as a student and post-grad, but nothing is set in stone. And even if you don't, I know Will mentioned too, that if you have an internship in the hospital, I think that it's probable. It's not necessarily deterministic, right? So thinking about if you have an internship in a hospital, you're much more likely to probably get hired because the idea is, the ropes, right? The system, what's happening. But that's not to say that if you'd like to have another experience, you're not sure about hospital social work or medical social work, then post-grad you decide, that's okay too. As long as you have your MSW, your license, you interview well, consider the aging and health certificate. It's a really great way to also get into the context of the major hospitals in the state. You'll be great. Sorry, Will, I just wanted to make sure that was clear.
No, I would like to add too, because I was an aging and health fellow myself and everything. At least at my hospital, when I was an intern and when I got hired, I found that the coursework within that certificate program was pretty helpful, especially like, what was it? It's like chronic illness and disease, I think was the class. I might be mispronouncing the name.
And disability.
And disability, yep. And then there was social work health. I found that more helpful than social work aging, at least for the hospital. But everything I took within the certificate was extremely applicable, even if it was more macro based or more micro based. Are you, Mimi, are you currently a first year student, or are you thinking, or where are you in your MSW journey?
I'm not in the MSW program, so I'm a senior.
Okay.
Undergraduate program, a senior. I'm starting the MSW program next year, but I've been going back and forth in terms of the specialization and track. And I started my internship at a hospital, at a clinic a few months ago. And I just love it. I just want to be there. But I didn't know if I needed a clinical degree or management and policy degree to be able to do that.
Yep,
and
it doesn't
also,
matter.
Okay, and also with a certificate program, I see it's aging and health, right? And when I went into it, I see that there are only 2 courses required for the health. Do I have to take the aging part of the course as well, or I don't have to?
So for thank you so much, Mimi. Great question. And I put the brochure in the chat, and obviously check out the website as well, part of Rutgers School of Social Work, and I'll put that in the chat in a moment too. But we have 2 required courses per the Aging and Health Certificate program. One of them is called Loss Across the Lifespan, which is a very popular course, very similar to human behavior in the social environment, sort of understanding development and different types of losses that can exist. Then we also have policy class that's focused on aging, particularly Medicare, Medicaid, benefits of that nature. And then out of 4 classes, you'll take 2. One of them or 2 of them are clinical social work health, clinical social work aging. So you choose one out of those. And then the other is chronic illness and disability, another very popular class at the school, as well as aging services, a critical perspective, which you would probably be interested in given your MAP enjoyment of MAP related things.
Yeah.
But they all have, you know, as you know, maybe, or you're suspecting, and Will could attest to this, it all jives together when you graduate. So you can focus on one in your MSW, because we really want to make sure you get maybe specific skills in an area of practice. It's all going to work together once you graduate. But those are the courses. And again, let me see if I can put the link to the website, or if you looked at that, but you can always email me too.
Okay, awesome. Will, one last question.
Sure.
I wanted to ask if after your internship, when you're looking for a job, were you looking for a specific kind of job, like a job title, or you were just open to experiencing anything?
So when I graduated in May of 2020. So I graduated right, the pandemic blew up. So like I wanted to work in a hospital. So I knew that the Robert wanted to hire me, but the job wasn't being offered. Like they were giving it to like the nursing students first, because they're bedside and everything. So I at one point applied to Capital Health. I had an interview. I obviously didn't go there because they didn't hire me. Then I got I can jokingly say kind of desperate, but it was just because I needed a job. I applied to some mental health nonprofit, and not to sound like I'm poo-pooing it, because it might come off this way, but the salary they offered me was horrible, and they couldn't even guarantee supervision, which I'm not really interested in full disclaimer, but again, that's why it's important to ask. So I was kind of in a rut, and then finally I had my interview with Robert Wood, and then I got hired. But I was specifically looking for like hospital social worker. I would also recommend, if you want to still go this route, you could also call it like care coordinator, but make sure to put social worker afterwards, because a care coordinator could also be a nurse, an RN case manager, which just for everyone's knowledge, when I say a nurse case manager, it's basically they are bedside nurses who converted to care management. So they no longer want to work bedside. So, but those are the 2 things I would look for: medical social worker or hospital social worker, and then care coordinator. So
Okay.
3 things. Yeah.
Thank you both so much. I really appreciate it.
Yes, you're welcome. Megan, I think we had another person. Emily, yes, Emily Barth. Did you still have a question? I think you were next on my list, but
yeah, thank you so much. This was super helpful. So I was just wondering, so Will, you said you did do like discharge coordination. So is that considered like clinical social work? And is that like the main role social workers can have in a hospital, or do people do like therapy as well, or is it mostly like discharge work?
So it depends. So I'm in the care management role, so that's discharge planning, but we have a palliative social worker on who's in her palliative department. That's definitely really clinical. We have an oncology social worker who deals with, like, I work in the oncology unit, but again, I'm discharge planning. So the oncology social worker follows these patients from start to finish, and sometimes even when they're in their homes, and does more therapy or like clinical based stuff. So the opportunities in hospitals, and I would even extend this to health nonprofits, are endless. I constantly am working with the hospice social workers on staff, because when I'm coming up with a discharge plan that involves hospice, I want to make sure like I have to follow my regulations from the state and everything, and I want to follow up with the hospice team to make sure that the family's wishes are, being met. And I would argue that they have a more clinical role than me, in the sense of they're dealing with the families, constantly talking about the emotional aspect of what they're going through. Not to say that I don't do that, But again, my primary function is planning discharges. Where I would argue, a one-up over my nurse case manager colleague is I have that training of starting where the patient's at, starting where the family's at. Let's de-escalate. Let's, get around the diversion. Like, I have that kind of training, even though I'm not in a traditional, let me sit down and talk to you about your feelings role. So, to answer your question in a nutshell, it just depends on the specific job title. Because even if you look at the Barnabas site, you would see it would say case management. Like, that's a role I'm in. You would see palliative. You would see oncology. So just when you're looking for a job, just really pay attention to the title and the job description. Because just to give you an example, when I was fresh out of grad school and was desperate for a job, I applied to, must have been some pediatric like palliative social work job. I didn't read the title clearly and the job description. And when they called me for an interview, I was like, oh my God, I have absolutely no training with kids. This is going to be horrible. And I obviously didn't get it because I have no training. So just pay attention to what you're applying to.
Great, thank you so much.
Of course. I think Megan has a question.
Hi, yeah, thank you. Will, this has been so amazing to hear all of your experience. And so I am not currently in the MSW program and prepared to get your deer in headlights shocked look on. I have no background experience in social work. I've been working in arts nonprofit for most of my career.
Okay.
And I've recently started working at a clinical research organization trying to kind of find a way in the healthcare field. And a recent experience sort of showed me that maybe medical hospital social work is the way to fulfill those desires I have. So my big question for you is regarding just the overall dynamics of working within the unit and team that you described. So obviously there's a lot of moving pieces every single moment of your day. How do you find your role is prioritized in terms of how often you get face-to-face interaction with the patient? Like, do you feel like you're able to get what you need to do your job in the day, or do the other clinical aspects of the case get precedence?
So first, that's a good question. And also secondly, sounds like you're a career switch. So welcome to the field and everything.
Thank you.
But to answer your question, it depends on the case. So if a patient is trached and pegged, like they have a breathing apparatus and a feeding apparatus, a doctor, and not to throw shade, but when a doctor asks me, can you go talk to this patient? I might give him a look and say, you really want me to talk about a discharge plan when this guy is breathing on a ventilator? Really? So, jokes aside, when I need to see a patient, I leave my office, I go to the bedside and I talk to them. If I need to talk to the family, if they're at bedside, great, I go to bedside. Otherwise, I call them on my work phone. I find that I personally do get enough time within my day to see who I need to see. Because remember, my job, even though there is patient interaction, a lot of my job is also desk work because I'm coordinating a ton of stuff. So I find in the beginning, I struggled to get that balance because there were times where I wanted to stay with the patient and like let them vent, but I have gotten very good at getting what I kind of need in my interaction. And obviously I don't want to be cold and, malicious. So I do let them vent a little bit and I try to calm them down. And I might add as a caveat, I must be doing pretty well with that because I've gotten like 3 or 4 patient satisfaction gold stars since I've been in oncology. But it is a skill you have to learn. I would argue that given your previous career, you might be very good at relating to other the patients and kind of starting where they're at. There's no, creative types are, in my opinion, very good at relating to other people, whereas I can jokingly say this, and maybe Dr. Lauren can agree. When I was doing my fellowship project, I was pretty cut and dry. I was looking at statistics and everything. So, but yeah, I hope that answered your question to a degree before I start going on a tangent. But
Yeah, no, I appreciate it. Thank you.
Mm-hmm.
And I think, something else that comes to mind when I think about your role, Will, is just the interdisciplinary practice that exists in your role. So,
Oh, yeah.
you know, when I think about the clinical work, you're also likely, as I could recall my own experience, educating people about sort of the biopsychosocial and what's going on with the client and why we can't, you know, simply just send them somewhere or discharge them because there's maybe something else happening that's not medical or that's not on the face sheet that we know about. Advocating for things like charity care, which you can explain. So
Sure.
there are a lot of other aspects of the job that have a social justice connection. Maybe you can go into that a little bit.
Yeah, no, I definitely can. So I think what Dr. Lauren's also trying to point out is even though my primary function is discharge planning, I am still doing a lot of, I'm using clinical skills, but I'm not sitting down with my leg crossed with a pen in my hand and being like, all right, CBT. Like I'm not doing that kind of work. But to answer the biopsychosocial side, like when I do a care plan assessment, or if my nurse case manager does it, we're looking at who do you live with, what insurance do you have, really pragmatic stuff like that. Do you feel safe at home? Things of that nature. And if you don't have insurance, we go into what's called charity care. So charity care basically covers the hospital stay, and the hospital has to, you know, foot the bill on that. However, if a patient is eligible for Medicaid or emergency Medicaid, whatever it is, we can get them started with an application for that. Now, it's, you know, it's kind of a catch-22 in a way, because yes, we get you started for it, but you can't stay in the hospital while the whole application processes. But as long as it's started, you're one step better than you were. Not sure if that really answers your question, Dr. Lauren. I can go on and on about it, but
Yeah. I think it was just a question, sort of like building off of the tasks and the things that you do, because
yeah,
certainly as you've been in the role now for a while, it can seem sort of like a checklist, and sort of helping the students connect, especially students who are just starting their MSW or haven't started yet, thinking about sort of the other reaches or other influences that this type of role has in a patient's life. It's a lot of crisis intervention. You know, you might be working with or calling on behalf of a client or a family member, you know, protective services, depending on the age of the client or patient. And there's obviously a lot of connection with the community and thinking about clinics and their connection with the emergency departments. I know in Plainfield, there's a Rutgers Hope Clinic that's connected to, I think, St. Joe's. And so they have sort of a back and forth of clients going to the ED and then this clinic for the uninsured, and the social worker follows them throughout. So there's just so much happening with health systems today. And something to take away is also that while we are all living longer, we're all living with the complexity of different things happening in our lives. So there are jobs. Emily, I think you had another question.
Yes, thank you. So I was wondering if you've ever experienced like burnout in your job. I can imagine the nature of the work can sometimes be really emotionally intense. So I was just wondering how you deal with that.
So I'm the only male social worker, so I will make the joke, and I joke with my colleagues all the time, that the way I get my frustration out is kind of stereotypical guy. I go to the gym, I started boxing. I don't actually fight anybody. I don't actually want to have my head punched in. But I do stuff like that. Whereas my, you know, my female coworkers and even like my nurse friends do this as well. Like they more or less, like, they eat lunch together, they vent about it and everything. But we also all go out, you know, sometimes after work and just have a good time, laugh it off. Or if someone really had a awful day, we just think, you know, this one's on me kind of thing. Have I personally experienced burnout? I would say no. There were days, especially when I first started, where I was really overwhelmed. Dr. Laura might get a kick out of this. When in my first, like, I want to say 4 months, I got basically verged or written up like 4 times because I was so aggressive with other like disciplines, because they weren't like speaking nicely to like myself or like one of my patients. And I've obviously learned how to politely disagree with the care team and everything. But I would argue I only acted like that because A, I was standing up for my patient, and B, I was really overwhelmed. But I practice meditation now. I'm pretty laid back. Very few things at work really bother me. And everyone I work with will say that if I look a little stressed, then it means something's really bothering me, because now I'm pretty loosey-goosey with how I go about my day. I like to pull jokes on people. It helps, especially in oncology where it's so sad a lot of the time. Like, just the camaraderie with the other departments is helpful. And as I said, like, I prank some of the nurses. I've pulled jokes on like some of the doctors. Sometimes they get me back, and it all makes the stressful environment just a little less stressful.
Great, thank you so much.
I also like what you shared, Will, because it sort of also encourages us to realize that we are social workers, we're, providers, we're clinicians, we're professionals, but that doesn't mean we have to sort of stifle all aspects of our personality. The days of where social workers and providers need to be like a complete blank slate are far over. It's nice to add your personality into your practice and into, your interactions with your team members. And I know that especially first year MSW students might be coming from undergraduate degrees that kind of talk about the blank slate, or, thinking about disclosure. How much can I disclose? Certainly we don't want anything to be about us. It's about the client or patient in front of you. But as Will said, some lightheartedness, some laughing, some moments of just genuine authenticness are also really good to bring into some settings where certainly the news is very serious, and it's a very challenging kind of place to be as a patient or a client, and also as a worker. And I also put in the chat that, for folks, I know we're not there yet, for folks who are looking, in the future, you're absolutely encouraged to ask these questions in a job interview. You can ask about supervision, what it's like. Okay, if I can't get my clinical, licensure here, what other opportunities exist to advance? Things like that. You can also ask about self-care. What is it like? How does the team interact with one another? How is self-care prioritized at the agency or setting? That is becoming more and more important. We don't want our social workers to feel like, for example, we can't take a day off. Because if we do, everything will sort of go into chaos, which, quite literally could be the truth, but nonetheless, we want everyone to have that opportunity to take that time. Yeah.
I think Mimi had a question
Yes.
first before Emily.
Sorry, guys, I have one last question.
Right ahead.
About the coursework.
Mhm.
Since I don't have to specialize in clinical social work and do management and policy, that means I don't have to take intro to clinical social work 1 and 2. I would rather take management and strategic planning. So I would take all the MAP courses.
Yeah, so I think this question is for me. So you
Yes.
would take all the MAP courses, but I want to add something additional to what you're asking. If you are a MAP focused social worker, if you're interested in interning in a hospital, that could be a little bit more tricky, because typically hospital social work, sort of intern coordinators and such, they are looking for folks who are actually wanting to go into clinical practice. And usually management and policy focused interns are going to state agencies, Department of Health, maybe local county offices on health and aging. So it's not to say that it's not done, because some hospitals or some health related agencies have like a research project division of some, or there's a grant and they want, you know, a management and policy student to help with the grant. There's community health settings that would maybe take a management and policy focused intern. But typically speaking, I would say a lot of the interns going into hospitals are clinically focused. Now, if you're in the aging and health certificate program, and I'm not just saying this to sell this to you all, but if you're in the aging and health certificate program, one of the benefits of being in that program, besides the benefits that Will listed, is, you know, simply the fact that you're working within a smaller pool. So you'll be working with me, and I have a smaller group of students that I work with as part of the certificate, and I could maybe help change that reality. No guarantees, but I could maybe use my contacts, and I might have a little bit more time to look into that option for you. Rutgers is a big school, so sometimes the bandwidth is hard for our folks in field who, you know, are trying to meet the needs of hundreds of MSW students. So a certificate program of any kind is sort of an opportunity to have a little bit more of a closer community and contact with a faculty member.
I will add, a lot of my coworkers, regardless if they were MAP or clinical, a lot of us, including myself, were aging and health certificate people. And again, I can't reiterate enough just how important it is, regardless if it's the micro or macro aspect. I took every single class of the certificate, even though I was clinical, because I also personally enjoy like the budgeting stuff and like policy things, like as a hobby. But I just found that all of it, because it was all built around health and aging and just the system in general, it was just helpful. Because the way I explain it, I say it to my other coworkers, especially the non-social work people I work with, in order to understand, you know, the ground level, you have to understand the higher level, and it all connects. Even though, you know, if you're working on a macro level, you might not see it necessarily, because again, you're not in the trenches. But regardless of where you are, everything you do is affected by this macro thing.
Also, could I possibly specialize in MAP and then take some electives in clinical social work, or do it the other way, specialize in clinical social work and take some courses in management and policy?
Yes, as long as you're meeting the requirements for the track. So if you decide I'm going to stay clinical, but I'd like to take a few extra MAP courses because I like MAP, it depends on, you know, of course you have to meet the track requirements for graduation, and then you can intersperse with different electives, but you know, that could change your graduation date. So you might look into advisors, you might look into 1-credit courses, you might look into special student interest groups. We have a whole policy network that is sort of like intended for the management and policy students, but they put out a newsletter and they have events and they're open to all MSW students. So there's other ways to get involved. Certainly we have faculty that are, you know, MAP experts that you can stay in touch with as well. And yeah, you have time, so don't worry too much.
Thank you so much. I really appreciate you both.
Of course, no problem.
So we're nearing the end of our time together. I just want to make sure that anyone else might have a question in the last 5 minutes together. Mimi, do you have, okay, Myrta, another one of our aging and health certificate students and one of our amazing Taub fellows, go right ahead. Welcome.
Hi, I'm sorry. I'm doing 20 things at once. I just wanted to say thank you for putting this together. I learned so much, and definitely going to think about some of the things that were said today. And I love the aging program. Anybody thinking about it, definitely look into it more. And if you ever want to talk to me, reach out. I'm a big Dr. Lauren fan. Go Rutgers.
I'm a big fan of Myrta's too. Thank you so much. And let me just turn it back over to Will if you want to sort of share any kind of closing remarks before we break for the day.
I mean, I guess I can wrap it up by saying that regardless of where you are in your MSW journey, or even if you're a BSW or just a BA student, I kind of live by this quote. It's an Eisenhower quote, which are plans are nothing, but planning is everything, which it roughly should translate to goals are nothing, but planning is everything. And what I mean by that is a lot of you guys have goals, but you have to really break down how you're going to get to that particular goal. Otherwise, you're just being whimsical in the wind. And while that's good for being relaxed, that's not good for planning a career. So kind of how I presented my PowerPoint, where it was pretty cut and dry, like internship, do this, do that, pass. Put in the time now, and then you should be able to see the fruits of your labor. And obviously things change. So always be able to adapt, but just keep in mind that it's great to have a goal, it's great to have a dream, but just make sure you're planning, asking people to assist you. Otherwise, you're going to be floating in the wind, and that doesn't help you.
Great. Well, thank you so much, Will. We so appreciate you giving us some of your time today, giving back to your alma mater. We're so thankful for your discussion and your opinions and your just everything that you shared today. I think it was really helpful to the students on the call. I want to remind everyone to stay in touch with me as well. My name is Lauren. People call me Dr. L. I'm on faculty and I'm the coordinator for the Aging and Health Certificate. So please reach out. I'm happy to answer questions. I'm happy to stay in touch. We will be having another speaker series in November, led by a colleague of mine from private practice world. So they will be delivering a discussion similar in format, just kind of like a lunch and learn, but later in the day, on private practice. What is private practice? What is it like to start your own private practice? So I know many people are interested in that at the MSW program. So my colleague Molly will be demystifying that for you and giving you sort of that 101 easy kind of information about it. I want to thank everyone for joining, and I hope everyone has a great day. I'll be reaching out to you to thank you as well and sharing the recording. And again, thank you to our wonderful speaker, Will. We're so proud of all the work that you're doing. And again, thank you so much for joining and leading this really amazing discussion.
No problem. Thank you for having me.
Thank you. Thanks, everybody. Take good care. I'll stick around for a few minutes in case anyone has any questions. Thanks for joining. Great. Okay. Excellent. Let me just stop the recording.
Sure.